So, Meshary, you can go ahead. Bismillah.
Okay. Assalamu alaikum. Good evening, everybody. I'm Meshary Aldhufian, abdominal imaging fellow in King Khalid University Hospital in Riyadh. First of all, I would like to thank the Body Imaging Committee for giving me this opportunity today to present a very important topic about the dynamic pelvic floor MRI, which is more commonly known as MRI defecography. However, the defecography part is only one part of the dynamic pelvic floor assessment. The presentation will take around 30 minutes. We will start by showing 6 cases in short videos, and for each case, we will have 15 seconds of pulling. And then at the end of the presentation, we'll go back to discuss the cases findings. However, before we start the cases, I would like to ask the attendees if they are currently doing the dynamic pelvic floor MRI assessment in their institutions or not. So kindly answer by yes or no. So thank you for your participation. Now, as we can see, 87% of the participants are currently doing the dynamic pelvic floor assessment, while 13% are not yet doing it. So now we're gonna start our lecture by showing the cases. We will start by case 1, 65 years old lady presenting with constipation and incomplete defecation. This is a mid-sagittal fiesta dynamic image, which was taken during evacuation phase. So now I'm gonna start the pulling for 15 seconds. Please choose your best answer. So I'm ending the polling now. So 53% of the participants chose answer A. We will discuss that at the end of the presentation. Now we will go to case 2, 49 years old male patient with history of anal fissure, rectal bleeding, and constipation. We have here 2 dynamic images. One was taken during squeezing phase and the other during evacuation phase. So let's start by seeing the squeezing phase. And this is the evacuation phase. So now I'm going to start the pulling for 15 seconds. Please choose your best answer. So now I'm ending the polling. So the wide majority of the participants have chosen answer C. Now we're going to go to case 3. 55 years old, male patient with history of road traffic accident 30 years ago, presenting with constipation. We have coronal static T2 image and dynamic image during squeezing. So this is the static coronal T2 image. And this is the dynamic image during squeezing phase. So now I'm gonna start the pulling for 15 seconds. I'm ending the pulling now. So as we can see, 57% of the participants chose answer B, while 43% chose answer D. Now we will go to case 4. 55 years old male patient presenting with obstructed defecation. We have a dynamic image here taken during evacuation phase. So now I'm gonna start the pull. I'm ending the pull now. And as we can see here, 35% of the participants chose D, and 27% have chosen B and C. Now we're gonna go to case 5, 56 years old lady presenting with chronic constipation and rectal bleeding. We have a static sagittal T2 weighted image and a dynamic image during evacuation phase. So now I'm gonna start the pulling. So I'm ending the pull now. So 32% of the participants chose answer B, while 25% chose answer C. We'll now go to our last case, case 6, 30 years old, male patient with history of imperforate anus, which was repaired at birth. We have axial and coronal static T2 images. This is the axial image. And this is the coronal T2 weighted image. And then we have coronal T2 weighted image post-rectal ultrasound gel injection, which is this image. So now I'm gonna start the pull for our last case. Now I'm ending the poll. So most of the participants, 78% chose answer D, which is all of the above. So this was our last case. We will go back to the cases at the end of the presentation to discuss the findings. Pelvic floor dysfunction is basically the inability to correctly relax and coordinate your pelvic floor muscles when they get disrupted or weakened. It is a very common disorder, affects nearly 50% of multiparous women above the age of 50. And as we know, it significantly affects the quality of their life. Pelvic floor dysfunction can be caused by multifactorial risk factors. The most common cause is pregnancy and vaginal delivery related injuries to the pelvic floor muscles and fascia. Also, patients with chronic constipation or chronic straining can have pelvic floor dysfunction eventually, because a long-standing increased intra-abdominal pressure can repetitively traumatize the pudendal nerve, which, as we know, innervates the levator ani muscles as well as the external anal sphincter. Another cause of pelvic floor dysfunction is simply aging or menopause due to reduced collagen and elastin in the pelvic floor muscles and ligaments. The last known cause of pelvic floor dysfunction is prior pelvic surgeries, as it causes anatomical damage to the pelvic floor muscles and fascial layers. Patients usually present with either obstruction symptoms or weakness symptoms. The most commonly encountered in daily practice are the obstruction symptoms, such as constipation, obstructed or incomplete defecation, as well as organ descent or prolapse. The weakness symptoms can include either fecal or urinary incontinence, whether passive or urge, and it can also present as organ descent or prolapse. The pelvic compartments in female pelvis are divided into 3 compartments. The anterior compartment includes the urinary bladder and urethra. The middle compartment contains the uterus, vagina, as well as the cul-de-sac, which is considered part of the middle compartment. The posterior compartment contains the rectum and anal canal. In male pelvis, we have only posterior and anterior compartments. So the pelvic floor support depends on 3 main components: the endopelvic fascia, the pelvic diaphragm, and the urogenital diaphragm, which are arranged from superior to inferior, as we can see on those 2 images. The endopelvic fascia is the most superior structure. Then comes the pelvic diaphragm, and the most inferior structure is the urogenital diaphragm. So now we're going to discuss the endopelvic fascia, which is divided into 3 levels: level 1 endopelvic fascia, level 2, and level 3 endopelvic fascia. For level 1 endopelvic fascia, it is basically the uterosacral ligaments which suspend the upper vagina and uterus. Level 2 endopelvic fascia contains 2 structures, which are the pubocervical fascia and rectovaginal fascia. Pubocervical fascia is this structure here, which gives support to the posterior wall of the urinary bladder, as well as gives support to the middle vagina. While the rectovaginal fascia gives support to the anterior rectal wall, and it also prevents the cul-de-sac from descending in this space. Level 3 endopelvic fascia also contains 2 structures, which are the perineal body and the pubourethral ligaments. The perineal body is a very important structure in the pelvic floor, as it gives attachment to multiple fascial layers. As we can see here, the rectovaginal fascia as well as the perineal membrane or the urogenital diaphragm both attach to the perineal body. Also, the paraurethral ligaments are very important in fixating the urethra in its normal vertical orientation. So not all of these structures can be seen on MRI. What we can see on MRI are those 3 structures, which are the paraurethral ligaments, perineal body, and sometimes the uterosacral ligaments. As we can see on these MRI examples, we have here axial high-resolution T2-weighted image showing those paraurethral ligaments, and the smaller ones here are the periurethral ligaments. And when we go more inferiorly, we can see the pubourethral ligament. On the sagittal plane, we can see this T2 dark structure, which is the perineal body. And sometimes, whether on axial or sagittal plane, we can see the uterosacral ligament. So the structures that we can see directly on MRI, we can assess their disruption or weakness. However, the other structures that we cannot see them directly on MRI, we can still assess their weakness by looking for indirect signs of their disruption. So in the coming 3 slides, we will see what happens if any of these levels get disrupted or weakened. And we will start by level 1 endopelvic fascia defect. This is the normal appearance of upper vagina. When the uterosacral ligaments get disrupted, we will have this appearance of sagging upper vagina. So even if we didn't see the uterosacral ligament detachment directly, we can suggest it by seeing this appearance of the upper vagina. So this is an example of level 1 defect. For level 2, this is the normal appearance of a moderately filled urinary bladder. The posterior wall should be smoothly aligned, as we can see on this image. Whenever the pubocervical fascia get disrupted or weakened, we can have this sagging appearance of the posterior wall of urinary bladder. So this is an example of disrupted pubocervical fascia, which is part of level 2 in the pelvic fascia. Regarding the rectovaginal fascia, when it gets disrupted or weakened, the cul-de-sac will be able to descend in this space. As we can see here in this image, there is a peritoneum seal between the lower vagina and lower rectum, which shouldn't be there normally. So these are two examples of level 2 endopelvic facial defect. For level 3, which is basically the periurethral ligaments, this is their normal appearance. When they get disrupted or weakened, we can have widening of the radius space or the retropubic space, which becomes full of fat, as we can see on this image. And those patients usually clinically present with urethral hypermobility and urinary incontinence secondary to the disruption of these ligaments. So the second component of pelvic floor support is the pelvic diaphragm, which contains basically the levator ani muscles, which are the puborectalis and iliococcygeus muscles, as well as it contains the anal sphincter complex. The puborectalis muscle is best seen on the axial plane, forming a sling around the ano-rectal junction and keeping those three structures in a tight alignment, the urethra, vagina, and ano-rectal junction. These are two examples of disrupted or detached puborectalis muscle, and as we can notice here that the vagina has lost its normal H-shape configuration because of this detachment. The iliococcygeus muscle is best seen on the coronal T2-weighted image. This is its normal appearance with its complexity pointing upward. And these are two examples of atrophied iliococcygeus muscles. As we can see here, they are thinned out with their convexity pointing downward. And then we come to assess the anal sphincter complex on axial and coronal planes. And as we know, the external anal sphincter is composed of striated voluntary muscles, while the internal anal sphincter is composed of smooth involuntary muscles. So we have to assess the anal sphincter complex for the presence of any defects, any fistulous tracts, any abscesses, or even masses. The last component of pelvic floor support is the urogenital diaphragm, which covers the anterior triangle of the perineum and has two orifices for the vagina and urethra. The most important structure of the urogenital diaphragm is the external urethral sphincter, which when it gets disrupted or weakened, the patient will clinically present with urinary incontinence. Sometimes it might not be easy to assess the function of the external urethral sphincter on MRI, so it is more of a clinical diagnosis. Now we're going to talk about the MRI defecography or MRI pelvic floor assessment. In terms of preparation, fleet enema 4 to 6 hours prior to the scan is optional. Whether you do it or not, it will not affect the quality of the scan. However, we do ask the patients to empty their urinary bladder 1 to 2 hours prior to the scan. And the reason for that is to have the urinary bladder moderately filled at the time of scanning. We don't want the urinary bladder to be over-distended nor undistended at the time of scanning. Patient instructions should always be clear. The patient should know exactly what do we mean by squeezing and what do we mean by straining. Squeezing is basically the Kegels exercise or the muscles that we contract when we want to stop the flow of urine, while straining is simply the Valsalva maneuver. Another important point is patient convenience and privacy, which should always be kept during the scan, like by dimming the lights. Also, another important point, when the patient is a lady, it is always preferable that the technologist doing the scan is a female technologist, just to give the patient more convenience during the scanning. The protocol that we use, we start by doing static high-resolution T2 images with and without FATSAT along the anal canal to assess the anatomy and endopelvic fascia as we saw on previous slides. Then after that, we ask the patient to lie on left lateral position, and then we inject 150 to 200 cc of rectal ultrasound gel. And we use ultrasound gel because it is considered a semi-solid material. And usually incontinence patients are graded into 4 grades: incontinence to air, to fluid, to semi-solid, and to solid materials. Incontinence to semi-solid and solid materials are treated surgically, while incontinence to air and fluid is treated by physiotherapy. So whenever the patient is incontinent to ultrasound gel, it means that the patient is a surgical candidate. Then after injection of rectal ultrasound gel, we start doing our dynamic mid-sagittal fiesta images at different phases. So for the interpretation part, as we said, the static images for the anatomy, and then we start doing our dynamic images in 3 phases: the rest phase, squeezing phase, and evacuation phase. In rest phase, we assess the ano-rectal angle, or we measure it as a baseline measurement. Then we assess the ano-rectal angle change during the squeezing phase. We compare it with the rest phase. And then in the evacuation phase, which is the most important phase in the scan, where we can assess the ano-rectal angle change, organ descent, and obstructive causes such as rectocele and interceptions. The ano-rectal angle change, we'll come to that in details in the coming slides. But what if the patient couldn't evacuate? What should we do? We usually give the patient 3 evacuation trials with counseling. We have to explain to the patient the importance of the defecation phase to have a diagnostic and optimal scanning. However, if failed 3 trials, then we ask the patient to evacuate in the bathroom, and then we do post-emptying straining or Valsalva phase. So if the patient is unable to evacuate, we have to add straining phase. And this is because, as we can see on this graph, all abnormalities that can be visualized on a defecography scan are best seen on the defecation phase. The second best phase is the straining phase. So whenever the patient is unable to defecate, we have to add the straining phase as an alternative to the evacuation phase. It is also important to notice in this graph that interception can only be seen during evacuation phase and usually at the end of the evacuation phase. These are the abnormalities that we can encounter in a defecography scan. In the anterior compartment, we can see cystocele or urinary bladder descent. We can have urethral hypermobility. This is the normal orientation of the urethra, which is vertical. Sometimes with cystocele, the urethra gets more horizontal, which means urethral hypermobility. In the middle compartment, we can have uterine descent, and also we can have cul-de-sac descent in the form of enterocele, peritoneocele, or sigmoidocele. In the posterior compartment, we can have ano-rectal junction descent, we can have rectoceles, and we can have interceptions. Regarding the lines that we use in the defecography scan, the most widely used line is the pupococcygeal line, which is drawn from the inferior tip of the symphysis pubis to the last coccygeal joint. Some people, usually the urogyne people, they prefer the mid-pubic line, which is a line drawn along the long axis of symphysis pubis. However, the mid-pubic line is less studied and less used in daily practice. So in our presentation today, we will concentrate on the PCL. So after drawing the PCL line, we draw the H and M lines. The H line is basically drawn from the inferior tip of the symphysis pubis to the posterior ano-rectal junction, and it indicates the anterior-posterior dimension of the levator hiatus. The M line is drawn from the PCL to the posterior ano-rectal junction, and it indicates the levator plate descent. Normally, the H line should be less than 6 centimeters, and the M line should be less than 2 centimeters. Whenever H and M lines get beyond these measurements, we can have something like this, which is known as the descending perineal syndrome. or pelvic floor relaxation, which can be graded into mild, moderate, and severe using these reference measurements. So after drawing the PCL, H and M lines, then we draw 3 perpendicular lines to the PCL to reference points in each compartment. Reference point in the anterior compartment is the urinary bladder neck. In the middle compartment is the anterior cervical lip, and in the posterior compartment is the ano-rectal junction. And after drawing these 3 lines, we use the rule of 3 for grading this descent. From 1 to 3 centimeters considered mild, 3 to 6 centimeters below PCL is considered moderate, and more than 6 is large. It is important to notice that any descent of less than 1 centimeter is still considered normal. We start considering it abnormal whenever it goes beyond 1 centimeter below PCL. Another important point that it is preferable to use the word descent rather than prolapse, because prolapse sometimes can be confusing to the referring physician. Prolapse sometimes can be perceived as external prolapse. So it is always preferable to use the word descent. Regarding rectoceles, whenever we see a bulge in the rectal wall, as we can see in this image, we have to draw an imaginary line along the expected location of the anterior rectal wall, and then we measure this bulge, and we can grade it using the rule of 2 into small, moderate, and large rectocele. If the patient is clinically suspected to have lateral rectocele, we will not be able to see that on the sagittal plane. So in this situation, we'll have to add either axial or coronal dynamic image during straining or evacuation to be able to see the lateral rectocele. The last component of our interpretation is the ano-rectal angle, which should be drawn between the central or intraluminal axis of the anal canal and the posterior wall of the lower rectum. This is its normal range at rest. However, it is not important to memorize this range because it gets sometimes variable. What's important is to know how it changes during squeezing and how it changes during defecation. During squeezing, it should decrease or become more acute by 15 to 20 degrees. And during defecation, it should increase or become more obtuse by 15 to 20 degrees to facilitate the defecation process. Regarding reporting, the SAR disease focused panel have suggested a structured reporting template, which you can find on this link. It was published in August 2019. However, whether you prefer to use a structured template or not, it is always important that we keep in mind the clinical presentation of the patient when we report a defecography scan. If the patient is presenting with obstruction symptoms, we have to look specifically for these abnormalities: compartmental descent, rectoceles, interception, and puborectalis relaxation. And to look for these abnormalities, we need only rest and evacuation phases. If the patient is presenting with incontinence symptoms, we have to look specifically for these abnormalities. And to look for these abnormalities, we need to add squeezing phase to assess for the puborectalis contraction. So in both scenarios, we don't need the straining phase. We only need the straining phase only if the patient is unable to evacuate. In that case, we can add the straining phase. Now we're going to go back to the cases. Case 1. If we stopped here, if we draw the PCL line, we can see that all compartments are descending below the PCL. So we have tricompartmental descent. Also, if you notice that the urethra is getting more horizontal, which means urethral hypermobility. And urethral hypermobility, if it's present, it is very important to be reported because it changes the management. A patient with cystocele alone is managed differently than a patient with cystocele and urethral hypermobility, because in case of urethral hypermobility, the urologist will have to put a urethral sling to fixate the urethra in its normal vertical orientation. Same-wise, the sigmoidocele or peritoneocele, as we can see here, that there is a sigmoidocele and peritoneocele. It is always important to report it if it's present because it also changes the management. If the patient has peritoneocele or sigmoidocele or enterocele, the surgeon will proceed with an abdominal approach rather than perineal approach. Regarding case 2, we have squeezing and evacuation phases. And as we can see here, during the evacuation phase, we have persistent paradoxical contraction of the pubic muscle, and the ano-rectal angle did not get more obtuse or widen. And also the patient was not able to evacuate the ultrasound gel. So the combination of these findings is in keeping with pelvic dyssynergia or pelvic spastic syndrome, which according to the literature is found in a large number of patients with anal fissures, because those patients usually experience a painful defecation because of that fissure. And because of that, they become psychologically unable to defecate after that as an unconscious defensive mechanism by the body. And that's why they are treated usually by biofeedback, not surgical intervention. So this case was a case of pelvic dyssynergia at the level of puborectalis muscle. Pelvic spastic syndrome can happen on 2 levels, on the level of puborectalis muscle, as on this case, and it can happen on the level of external anal sphincter, which sometimes might be difficult to see on MRI. And that's why the proctology people use the ano-rectal manometry, which is a probe inserted inside the anal canal to measure the tone of the anal sphincters during resting and squeezing. Case 3, as we can see on the coronal T2 weighted image, there is severe thinning of the levator ani muscles, and during the squeezing, there is complete loss of puborectalis contraction. This patient had a pelvic trauma 30 years ago, which led to loss of the pudendal nerve motor function, which innervates the levator ani muscles and external anal sphincters. And because of that, this patient has complete loss of the puborectalis muscle contraction. Case 4, we have the evacuation phase. There is posterior compartmental descent, as well as infolding of the rectal mucosa inside the rectum, which is in keeping with intrarectal intussusception. So rectal intussusception can be divided into 3 types: intrarectal intussusception, intraanal intussusception when the infolding reaches the anal canal, and extraanal intussusception when it prolapses externally. This is a companion case of intraanal intussusception. As we can see here, the infolding is reaching the anal canal, however, it's not yet getting outside the anal verge. So this is a case of intraanal intussusception. For case 5, as we can see here, that there is a polypoid T2 intermediate to dark lesion along the posterior wall of the lower rectum. And during the evacuation phase, we can see that there is aggregation or infolding of the rectal mucosa at this level. So this lesion was then biopsied for relapsed malignancy. However, the biopsy showed no evidence of dysplasia or malignancy, but there is erosion with acute inflammatory exudate and mucosal architectural disruption. So the biopsy findings is in keeping with solitary rectal ulcer syndrome, which is a chronic benign disorder that happens in patients who have a long history of straining during defecation, which is usually secondary to rectal intussusception. And this repetitive rectal intussusception will eventually lead to mucosal ulcerations and injuries. However, it is important to note that the word solitary is a misnomer, because according to the literature, only 30% of the patients found to have, on proctoscopy, found to have a solitary rectal ulcer, while the rest of patients found to have multiple rectal ulcers. However, it is still known by this name. The last case, on the axial and coronal T2 images, we can see that there is severe thinning of the anal sphincters and levator ani muscles. And after rectal ultrasound gel injection, the patient could not hold the ultrasound gel, as we can see here, that there is soiling of the ultrasound gel outside the anal canal, which is in keeping with anal incontinence. So among the 6 cases that we have presented, we have only 1 case of incontinence, while the others are cases of obstruction, which resembles the daily practice. The most commonly encountered cases are obstruction cases. So the take-home message of this lecture, it is always good to tailor our approach and protocol to suit each patient differently. As we mentioned in the presentation, if the patient is presenting with obstruction versus if the patient is presenting with incontinence, we have different findings to look for, and also the protocol can change depending on the presentation. It is always important to assess both anatomical and functional abnormalities. Sometimes we concentrate on the functional part of the scan. However, the anatomical part can give much information, as we saw in the beginning of the presentation. Patient instructions should always be clear to the patient to have a successful defecography scan. For anyone who is interested to read about the postoperative imaging of pelvic floor repair, this is a good article published in 2016. You can find it on this link. And these are the references that I used in preparing this presentation. And at the end, I would like to thank Dr. Meshary Aldhufian, Dr. Badr Mutairi, and Dr. Hana Al-Falih for their great efforts in arranging these meetings and in the fellowship program in general. Also, I would like to thank Dr. Meshary Aldhufian for his great help in preparing this presentation and in providing me with the cases as well. And thank you all for attending.
شكرا مشاري يعطيك العافية. Excellent presentation.
الله يعافيك.
We'll allow time for any questions. اللي عنده سؤال بس you can raise your hand.
I believe there was a question in the Q&A sessions. It's by Dr. Shaima. She mentioned how to differentiate between pelvic spastic syndrome and ultra-short Hirschsprung disease. I could answer that just commentally, but I would also give the chance for our fellow if he has any additions. But from our limited experience, usually spastic syndrome usually have a paradoxical contraction, while ultra-short Hirschsprung, you barely see any contraction at all. So this is one differentiating point. The other differentiating point, Hirschsprung usually have a history since birth, while pelvic spastic syndrome usually is acquired later in life. I don't know if you have any addition, Meshary, or any.
For Hirschsprung disease, if they biopsy, they will be, it will show Hirschsprung's disease in the biopsy because lack of ganglion, while the spastic is functional mainly.
Yeah, but during the, let's say you have an exam and the patient is trying to evacuate. Yeah. So if there is a contraction, paradoxical contraction, this is one finding that help you more regarding the spastic syndrome. And the other is the history. Is it since birth or not?
في سؤال ثاني by Rad Gad. I would prefer الأخ Rad Gad to write your name. لكن we'll take your question. اللي هو سؤاله is it possible to have urethral hypermobility without cystocele and vice versa? سؤال مشاري.
Yes, regarding the urethral hypermobility, it is usually seen with cystocele. So we can have cystocele without urethral hypermobility, but not vice versa.
So if you have urethral hypermobility, it means there is a cystocele already.
Yes.
But